as is. So welcome guys to our fifth installation of the SWOCCS series. I'll let Anton introduce Dr. Peddle in just a couple minutes. I just want to reiterate the goal of SWOCCS and why we sort of came up with this concept is to provide practical and topical CME for Southwestern Ontario critical care providers throughout the entire spectrum, and try and improve the collaboration and cooperation between critical care centers throughout the region, with the goal of ultimately sharing common challenges and then things we can do to try and improve the care across the region as a whole. I think this is a really interesting topic because Ornge really is the thing that connects our critical care groups. So I'm really excited to hear this. I'll reiterate this at the end. This is the last session we're going to do before we take a break for the academic year or for the summertime. But we're in the midst of planning a new set of lectures for next year, and we really are interested in having feedback. So a different form than the initial sign-up form you may have seen is posted in the chat, and we'll post again and send out via email. And we would appreciate all feedback and specifically constructive feedback. We want this to be iterative and we want this to improve as we go. And so if you found this valuable, please take the time to tell us that and take the time to tell us how to make it better. And with that, I'll pass things on to Anton.
Yeah, thank you. And just to add to that, we really want to recruit some people for difficult cases. So if you have any, keep them in mind and please fill out the form and leave your email there. To keep going with our presentation, I have the honor of introducing Dr. Michael Peddle. We were supposed to have the two Mike and Mikes, but unfortunately, Dr. Lowell had a personal emergency he had to attend to last second. Dr. Peddle graduated medical school from Memorial University of Newfoundland and completed a FRCP in emergency medicine at Western University. He is a diplomat of the Royal College Physicians and Surgeons of Canada with an area of focused practice in pre-hospital and transport medicine. Dr. Peddle has worked as an emergency physician at London Health Sciences Centre for over 15 years. In addition to emergency medicine, his career experience spans both land and air pre-hospital transport systems, as well as emergency preparedness and response. He is the Associate Medical Officer of Operations, Education, and Operational Control Centers and works clinically as a transport medicine physician for Ornge. In addition to his work at Ornge, he is a physician with the Provincial Emergency Medical Assistance Team, or EMAT, and the Medical Director for the LHSC Emergency Management Program. And we are very honored as the SWOCCS group to be welcoming him and look forward to his talk.
Thank you, Anton, and thanks for the invite to come and chat with your group. I'm pretty excited to be here and to talk a bit about Ornge and sort of open that dialogue to the point of improving collaboration and helping people understand how the system works so that we can actually try and make it more efficient and have an opportunity to have some questions or discuss what those opportunities are from a systems perspective. So half a second here while I just fix my screen and then we'll get started. So as with all things, we want to have some objectives for the day. So I'm going to vary in one slide or less, summarize some of the evidence around the dedicated critical care transport and why we have it. And then I'll spend most of my time talking about sort of Ornge as a background, talking about some of the operational structures, and really in a means by which to help people understand some of the operational limitations that we have as an organization, so that we can make sure that we have open up a collaborative discussion about how we can improve things that are actually ongoing. So what is the evidence for dedicated critical care transport? Well, it really revolves around safety. And so I'm going to put up a lot of pictures today. I will reference some of those pictures so people have context, but the evidence around critical care transport teams and dedicated critical care transport teams really comes around the safety and transport of these patients between facilities or to facilities. A lot of these, the studies were done in sort of the early 2000s, around 2005 to 2008, which really highlighted it's not necessarily about the individual ability to provide care in the environment, but it's really about the technical aspects of care, being able to predict the technical challenges, adapt and manage those challenges in the transport environment. And so These pictures are taken as a bit of a time-lapse series. We are not on the life pack anymore, but you can imagine the challenges of having to provide ICU level care when you've got the noise canceling headsets, not able to use a lot of the tools that we normally would. And if you look at the confines of our space to deliver ICU level care, it's a lot tighter with very limited access to additional stuff. As we say, we joke from an medical operations side that the challenge is we can't get aircraft or helicopters big enough to take all the stuff that we want to. Because we need fuel to be able to fly, and so we are limited in what we can pack into the back of our aircraft and actually still be able to do the job that we do. And so a lot of the evidence really is around the safety and the ability of the crews to understand how to function within the environment that we work, to have a safe transport from point A to point B. Oh, the other thing I will add is I'm a very informal speaker. I'm going to do my best not to use my hand, but at the same time, if people have questions, feel free to interrupt me. Anton, if you see any hands go up, just let me know. I'm happy to be interrupted and take questions as we go through, or if people want to hold it till the end, I'm happy to take questions at the end as well. So,
yeah, Eric and I are watching the chat for you.
Perfect. So a little bit of background by Ornge. So the provincial air ambulance system has existed in Ontario since 1977. Around 2006, it became the actual Ontario Air Ambulance Service, and then that actually was transitioned over to Ornge as it is today later in 2006. What we do, or the way we look at what we do, is we save lives, we restore health, we create capacity, and we preserve dignity. And those are the four fundamentals for what we do and how we do it. So how does that look? So we are a not-for-profit charitable organization. We are overseen and essentially fully funded by the Ministry of Health. We are the largest aeromedical transport provider in Canada. We do, on average, about 20,000 patient transports per year. And we do that across 14 dedicated bases, which are 9 air and 5 land bases, and have a total employees between frontline and support of about 640. When you look at our distribution, we are across the entire province. We are a provincial entity. And so this is kind of our distribution of our various bases. And I'm not going to spend too much time talking about it because I know we're really trying to focus out on Southwestern Ontario today. But really across the entire province, we are expanding. As many of you may be aware, we recently added a Hamilton base for CCLA. During COVID, we added a Chatham base for critical care land ambulances. So we have expanded our footprint in Southwestern Ontario based on feedback from yourselves, as well as looking at our data and our resources utilization within the space. But we're continuing to expand. Just this year, the government announced that we received funding to expand our Sudbury base. So in 2026, we anticipate we'll see Sudbury move from just a single rotor base to actually a rotor base with 2 24/7 fixed wing lines as well. So that's a very significant expansion of our support or our ability to support the Northeast and be able to deliver the care that we do in Northern Ontario. So as I said, we've got a number of bases across the province. We have 8 staffed helicopter 24/7. Our fixed wings, we say 4 staffed fixed wings. It's a bit different than that, but essentially it's 4 fixed wings. We do have essentially 2 24/7 assets in Thunder Bay. And then we actually have a daytime and a peak time aircraft. So 2 daytime and 2 peak time aircraft. Those are based out of Timmins and Sioux Lookout. And then we have 5 dedicated staff critical care land ambulances within our system, Southwestern Ontario, that is in Chatham and Hamilton. Those are 12-hour bases currently. We also have 24/7 in the GTA for GTA truck, Peterborough and Ottawa. As a Peterborough's 12, Ottawa is 24. On top of that, we do have standing agreement carriers like SkyCare who do some of our work. And then the other not dedicated, but critical care land service that works with it, our team is the TPS, or Toronto Paramedic Services, which have a 24, at minimum, a 24-hour critical care land ambulance as well that supports the GTA and certainly goes outside the GTA. Currently, they do a lot of the vast majority of our ECMO transports, or almost all of our ECMO transports, realistically. From a level of care, we have 4 levels of care within our system right now. Critical care paramedics are top tier from a training perspective, and their scope of practice is fairly broad, being able to run pretty much all medications from an ICU perspective. RSI intubate. They maintain, some of our staff are IVP certified to be able to maintain IVPs in transport. TVPs are within their scope of practice. We have a core group that, as I said, from TPS, that are ECMO certified and certified to provide support to perfusionists for transport of ECMO patients. ACP flight currently remains in our system. We aren't currently training to that level anymore, so that will become at some point a legacy certification level, but we certainly have some ACPs within our system, flights within our system, and they are very close to critical care paramedic. The biggest difference is a few areas from a medication and a few tools that they don't necessarily have from a CCP perspective, but the vast majority of our staffing is critical care at this point. ACP land is our starting sort of our higher level. So that's where the paramedics come into the system and go from ACP land to CCP with our education program. The training to go from ACP land to CCP takes about 18 months to 24 months, depending on their residency time, but essentially it's about an 18-month training program. And then we do have primary care paramedics within our system that support some of our local airport transport services to move patients to and from their facilities out to airports, as well as within our SA system that do a lot of our next day transfers. And that is basically trying to ensure that patients can make it from their local area hospitals to tertiary care centers for appointments if they're unable to travel independently, and or for care. From a partner's perspective, we have a lot of partners that we work with, obviously, over 263, I would say, at this point on a day-to-day program. We work with basically any hospital corporation that exists within Ontario. We service the north and we are the sort of medical transport system for all of the nursing stations throughout Northern Ontario. We work with all the 59 paramedic services across Ontario to provide care, as well as the 22 different ambulance dispatch centers across Ontario. And obviously a big partner that we spend a lot of time working with, and we'll talk a little bit more about later, is Critical Ontario from a transport perspective. So what do we do from a transport perspective? As much as a lot of the news shows the pictures of our helicopters doing on scene, actually about 90 to 93% of our transports are actually interfacility transports. And so that is moving people from smaller centers to larger centers to receive definitive care, as well as repatriation and maintaining capacity within the system. A large part and an important part of what we do is providing service to remote communities. So I like to highlight this picture. This is a picture that I took a couple of years ago now. So this is our fixed wing in Fort Severn, Ontario. For those of you who are not familiar with all of Ontario geography, as I was when I moved to Southern Ontario, Fort Severn is the most northerly inhabited community within Ontario. And for us in Southern Ontario in the 401 corridor, we are currently closer to Jacksonville, Florida, than we are to Fort Severn, Ontario. And so when you think about that from a geography perspective, it's about an hour and 45 minutes fixed wing flight north of Thunder Bay to get critical care there, and then to your definitive centers, which would be Winnipeg, Sioux Lookout, or Thunder Bay. Usually you're looking at anywhere from an hour and 40 to 2 hour flight time to do that. So a lot of our, certainly a significant portion of what we do is servicing the north. We also manage TGLN, so we do all of the organ team transport logistics for North America, for Ontario, for TGLN, for the Ontario teams across North America. So that leaves the other 7%, which are the ones that make the news more frequently. So those are our on-scene responses. When we look at Southern Ontario, so our geography, we are generally secondary responders. So it is almost exclusively for trauma in the South, where we are responding to the 911 call through based on 911 dispatch, pushing that information to us. But almost exclusively, we are secondary responders, meaning local land generally arrives before we do, and then we either meet them at scene, meet them at hospital, and continue that transport to the tertiary care centers. In Northern Ontario, it's a little different. Up there, not only do we do primary scene response, or secondary scene response, but we also do a lot of primary scene response where the only access to care is by Ornge, and it is not only for trauma, but it's also for medical scene call. This was a picture taken by one of our paramedics where they actually landed on this outcropping and took a canoe to pick up a patient from where they were for medical response. And so, as I said, a lot of what they do is coming up with the logistics to safely transport patients and get them to the care they need. So how do we do what we do? And this is a bit to give a bit of sense of all of the pieces of the puzzle within Ornge, and hopefully I'll spend most of my time talking about the call logistics to provide a bit of context to how, as critical care providers in tertiary care or non-tertiary care centers, how you interact with Ornge, and happy to answer questions as we go through. But really, it is a multifaceted cross-disciplinary competency. We spend a lot of time working not only with our OCC, which is our dispatch center, but with our aviation colleagues, both pilots and engineers, our paramedics and our transport systems, transport physicians. We have a dedicated research team and an RSAC that works within Ornge to look at our data and our data teams. And then we have a fairly well-developed corporate services to really provide all of the support systems that are needed by our frontline staff. So OCC is really the external touch point for a lot of the people on this call. Their first interactions with Ornge is going to be through OCC. This is our OCC center where we've got our operations manager who sort of oversees the operation, and then it's split with our clinical, our call takers that are medical, and our call takers that are flight. And so basically within our OCC, you've got call taker medical, which is the people that take the information that you provide and enter it into our system, our dispatch system. And basically that allows our transport physicians to then review that information, ensure that we've got both a appropriate level of care and priority response for that patient. That then moves over to our flight planners, who then take that information, the A to B information, and start figuring out what is going to be the most operationally efficient response that we have for this for the call, be it fixed wing rotor or CCLA, based on the weather, assets, and sort of the operational realities of the day, if we want to call it that. And what that really looks like is transport ring. So within every region, and Southwest being sort of covered primarily by CCLAs and rotors, we have dispatch rings that help, and a software program that helps our planners identify what is the closest asset, as well as all of the travel times for that patient, from depending on where that asset is and where that patient has to go. And so sometimes that means the land asset is the fastest. Sometimes that means the rotor asset is the fastest, and it really just depends on where the patient is. The access to helipads, we'll talk a bit about that a little bit later, as well as what is currently assigned and available within our system. One of the things that people don't necessarily have a great line of sight on, and I try and highlight whenever I talk to healthcare groups that interact with us, is that we actually have a 24/7, there's a transport physician sitting in front of a computer managing the board, as we call it. And essentially the role of that physician is a number of different things. It is to actually review every single call. All 20,000 that come in get reviewed by a physician for level of care and priority. We'll talk a bit about priority and what that means from an Ornge perspective. We will we'll connect with the sending facility to provide advice prior to transport, and then work with our crews to actually plan the medical care for transport. And the transport physician is the MRP, for lack of a better description, from the time we depart the sending facility till we arrive at the receiving facility. And that is split between two groups. We have a group of adult emergency medicine critical care certified physicians, and then we actually have a group, and we also have a group of pediatric critical care emergency physicians that oversee all of our pediatric transport. And I always highlight when I talk to groups that if you have questions about the transport, when you book the transport, either there seems to be a delay that doesn't make sense to you, you have questions about the capabilities of Ornge being able to move those patients, or anything related to that transport, don't hesitate to reach out and talk to our transport medicine physicians. Like I said, we are on the board 24/7, reviewing every call that goes through that. We talk to 80 to 90% of the sending facilities that are sending out these patients to have conversations about the transport logistics for these patients. And so we're happy to take calls and discuss things, because sometimes, as with all things, information is lost in translation. And so if you ever have questions, don't hesitate to reach out and talk to our transport physicians through the OCC. One of the other questions that we get a lot is how do we triage or prioritize our patients? And not unlike any other healthcare organization in Ontario, the calls for service exceed our capacity at any given time, which means that we do have to triage and plan our transports accordingly. And so we have developed our own triage and acuity scale. It looks for those of you who are emerge doc, looks very similar to CTAS. We've tried to align it to some extent, but essentially it's broken down into 5 categories. Emergent 1 being our life or limbs. So our best effort to get that patient to receiving is going to be within 4 hours. Emergents 2 are 6, urgents are 12, non-urgents are 24, and then non-urgent 5s are 48. And really what that allows our flight planners to do is to try and optimize our resource utilization and ensure that we're trying to meet those timelines. And there's multiple factors that go into determining whether or not a patient is an E1 to a non-urgent 5, and it can be related to the patient acuity, can be related to whether or not it's a scene call where there's a lack of medical care available to an interfacility where you're already in an ICU. Often it is influenced by the sending hospital capabilities. Different hospitals have different capabilities, obviously, and so that comes into play from a timeliness to transport, as well as the local EMS resources and our goal to get these patients moved across their distance. And so at any given time, we are shuffling these priorities or acuities based on the information that we're getting. And sometimes that is the helpful conversation that comes from us calling to talk to you as the sending provider, saying, we want more information to be able to ensure that we, based on the information we have, are providing the appropriate acuity for the transport. So we do definitely have challenges, and we hear those challenges, and so I'm going to highlight some of the things that we hear as challenges, and I'm happy to hear any other challenges and do my best to answer them for you. But the challenges that we often hear are related to communication. We often hear land is faster than air, and we'll talk a little bit about that. We certainly hear that sometimes it's easier to arrange local land than air transport, and I appreciate that. And then the other thing that we quite often hear is that Ornge spends 2 line, even when they come, it takes a long time for us to package those patients and transport them. And so I'm going to address each of these, and I'm happy to take questions as we go through if people have thoughts. But so communication, the thing that we often hear is that it takes a long time, or there's repeating of information only to find out Ornge is not available, or it takes a long time for us to make a no-go decision. And so there is no doubt that often there is a repeating of information, especially for life or limb patients as you move from critical to Ornge to the Ornge transport position. And we are working with Critical to actually try and help improve those communication lines, shorten that time from the first phone call to what we are able to sort of when we're able to respond. We've developed a procedure with Critical now that actually, once you've started that phone call with Critical and have the accepting, it actually gets pushed to our planners before our medical call takers to look at asset availability, and they will provide back to Critical on that initial phone call a rough ETA based on our current asset availability. And so we're doing that to really try and help provide that first ETA, or how long it's going to take for us to get there, because sometimes it's going to take us time to get there. Those numbers can change though, because sometimes it's a function of the acuity of your patient against the acuity of the patients that we currently have in the queue. And the best example that I can give is that, sometimes the helicopter is already assigned a call. And so the planner will say, well, we don't really have a helicopter right at this moment. But as you provide more information and we are able to then triage that and start looking at the acuity of the 2 calls that are available, it may be that helicopter can be triaged away from its current call. And so we really are trying to shorten that time for information so that we can improve and expedite that discussion. And this is where I really think that MD to MD discussion is helpful. And that's why you'll often see shortly after talking to Critical, you'll have someone from Ornge reach out, and really it's often to ensure that we have an appropriate asset and figure out the triage that may need to happen to ensure that we're able to service the calls, the most appropriate calls, in a timely fashion. And that comes back to the whole idea that sometimes land is faster. And I'm never going to argue this point, that sometimes land is faster and sometimes timeliness is more important. And that is absolutely the case. Sometimes there's no way we can be faster than the ambulance that's already sitting in your emergency department or sitting at your hospital, and you have local staff that can go with that patient. There's no doubt that we can't beat that sometimes, and sometimes the most appropriate thing is that patient needs to get to definitive care in the shortest time possible. My always caveat to that is the only way you know if they're going to be if local land is going to be faster than us is to ask the question. And that again comes back to this physician to physician communication to actually have, if you're not sure, reach out and ask, and we can tell you when we can be there. And certainly we've had cases where it just so happens that the London helicopter is overflying a scene and can land fairly efficiently and move that patient faster than the local land ambulance can. But other times they're already on a call, or they're a 30-minute flight to get to where you are, so maybe it's faster to get in that local ambulance and go. And so always I try and stress the communication, and asking the question is definitely the what I would say is the best thing to do. And the TMPs are there 24/7 and happy to answer those questions.
Sorry, Mike, can I ask a question there?
Yeah, absolutely.
So, I think everyone who's called Ornge has been in this situation before, and it seems like we're either calling OCC to get a hold of the TMP or the sending facility doctor. Is there any method to get all three people on the line at the same time to better coordinate?
Yeah, absolutely. So if you call into OCC, oh, sorry, go ahead, Eric.
So I'm gonna speak out as like one of the people who uses Ornge a lot in my TTL role, but still it's hard for us for the people who don't use this a lot to follow the acronyms. Can we maybe make sure that just everyone's using that? Because I think that's probably something that I struggle with personally.
Absolutely. Sorry, I appreciate that. And Ornge has a ton of its own acronyms. So OCC is our Operations Control Center. So that is the first touch point and there's a 1-800 number that I can send out to everybody that allows you to reach out to and contact us. And that will get you directly in contact with our call taker, who can put you on the phone with our transport physician, or TMP is our transport medicine physician that's working. So back to your question, Anton, absolutely. My suggestion is call the OCC, so our medical call takers and TMPs have the ability to conference in as many people as we want. And so if you are the receiving center or the sending center and want to have a conversation with multiple groups, what I suggest is the easiest thing to do is call into OCC, get the TMP on the phone, and while that conversation is ongoing, our COMs or our medical call takers can also get anybody else that we want involved. And certainly on our complex transports, our highly unstable transports, where we're trying to figure out, what is the best plan for this, we will through OCC often coordinate a phone call with both the transport physician who will be overseeing the crew that's assigned, the sending, as well as the receiving staff, to be able to have what I call a conversation that allows everybody to be on the same page and understand what our plan is from a transport, what our no-goes are, if there are any, and ensure that the care that we're going to provide, because as the MRP during transport, what I want to do is as seamlessly as possible transition from the care that sending is providing to the care that we're providing to the care that the receiving will be providing. And so if there's ever a question you want to have a group conversation, OCC is able to facilitate those.
And are those calls recorded like critical?
Correct. They are all recorded. So there's those, and they are recorded and considered part of the sort of can't remember what the official term for them are, but they are saved for however many years is required under the Health Information Act.
Thank you.
Perfect. So one of the things that I do like to highlight about going with local EMS, and it's not to say not to go with local EMS. Like I said on the last slide, there are times where timeliness is more important, is the priority. is just to recognize some of the challenges of going with local EMS. And in my previous life in the land system, so obviously staff challenges are one of the things we hear about. That is essentially, do you have the staff that are able to do it? And are you able to spare the staff in your facilities that are able to do it? And that is the first thing. One of the other things to look at is to consider the impact on local EMS services. If you're driving a land ambulance out of its encatchment area, an hour or two to move a patient to a receiving site, the land systems deployment plans are based on those ambulances being in service. And so if they're out of area for 2, 3, 4, 5, 6 hours, that does impact their ability to respond to 911 calls. And the other thing that I think we often don't necessarily think about is the logistics and securing of the equipment, especially for these high acuity patients. So recognizing that if you're going in the back of that ambulance, you've got to bring all of your drugs and equipment to go with that patient, because the land services will not carry the majority of ICU medications. Most of them are going to be PCP crews, so they are really symptom limited to symptom relief. And one of the things we're seeing more and more is concerns from local services for securing things like your infusion pumps, monitors, which may be different than the monitor systems that they have, and especially the vents. And there are requirements from health and safety as to anything that weighs under 22 pounds, I believe, has to be appropriately secured in the back of ambulances for transport. Because for those of you who have ever seen ambulance accidents, you know what they don't want are 5, 8, 10, 22-pound pieces of equipment becoming projectiles in the back of those vehicles. And so you really have to consider how you're going to secure those to ensure both patient and provider safety in the back. And recognizing that the land ambulances are different than the Ornge CCLAs. And that was one of the things we saw and talked a lot about in COVID, is the oxygen capacity of land ambulances is different than the oxygen capacity of Ornge critical care land ambulances. Our land ambulances have a much larger oxygen capacity, which allows for the provision of high flow or ventilated patients with high FiO2s that may not be possible in some of the land ambulances, depending on the duration or the distance that you have to go. So things to consider when you're going with local land. Like I said, not saying that it shouldn't happen, just saying you want to consider those things if those are going to be if that's going to happen. So certainly we've heard it takes too long for you to package patients, and that is something that we have spent a considerable amount of time looking at, both from a research perspective and then trying to improve from a logistics perspective. And the ways we've done that is one, through equipment. And what that I mean by that is really trying to ensure that all of our equipment is readily available to our crews when they arrive, with our bridges, so that they're not unpacking and having to set up equipment to be able to move patients. Standardization, which is one of the things that I like to bring up to ICU groups, is the variation in how medications are mixed and infused. Every ICU, I shouldn't say every ICU, but many ICUs have their own standard mixing protocols, as well as infusion dosings. So Ornge has, from our perspective, standardized to weight-based dosing to try and maintain some consistency within our system, but really and have started conversations in some areas to really try and have all hospitals within our encatchment try and develop a standardized, here's the dosing, here's the mixing, so that it makes our medication switchovers safer as well as more efficient. As many of you may have experienced, especially on our sick patients, you tend to end up getting a phone call from one of our physicians, and that is really to improve our packaging times. one of the things that we have looked at and studied and has been shown to improve our packaging times is pre-packaging. And what that means is our docs end up talking to the sending facilities to get very detailed information, far more detailed than is taken in our general call taking piece, right down to, you know, what is the specific doses of the medications being run, what are the current vent settings, what has been the transition or the sort of change in vent settings, change in medications. And then we will talk to the crews that are on the way via either cell or sat phones to actually have that conversation and pre-planning the transport piece. And what we have found is that transitioning to that doc calling the sending prior to crew arrival, getting those highly detailed pieces of information, and then talking to the crews, is we're able to significantly reduce our time in facility, because the crews are able to pre-mix all of their medications and infusions. They're able to set up the vent circuit, and know basically what the plan is before they arrive. And so while I appreciate sometimes that's a second phone call or a third phone call that you're getting from Ornge, the goal of that is really to help our crews be more to help improve the efficiency of that sort of patient transfer when our crews arrive. All right, feel like I've talked a lot, but I'm almost done. The other thing that I like to talk a little bit about is operational practicalities. I'm not sure if anybody on the phone are pilots and can appreciate sort of a pilot weather briefing, but they're very different than the weather that we see when we pull up our app and look up a weather report for wherever we are. And so one of the things that I like to highlight is that even with nice weather in one place, that doesn't necessarily mean that the weather is going to allow us to fly, because it may be related to the weather where the aircraft is. It may be related to the weather where the aircraft is going, maybe related to the weather between those two sites. And it may be just a function of temperatures and the altitudes that the aircraft need to fly because of cloud or obstacle clearance or many of those other things. And so it's suffice it to say, looking at that map looks complicated. That is a typical weather day for our pilots to start figuring out how they do that. And in Southwestern Ontario, sometimes that I like to call the bridge season in the spring, where it's kind of right at that 0 mark, but it's cloudy and foggy. That becomes a problem because helicopters have to fly at a certain altitude, and once they get to that altitude, it's icing. And so that's a problem. The other thing that we struggle with sometimes, especially in the summer as we get into thunderstorm season, is thunder cells popping up. And while our pilots are able to navigate around them sometimes, that's not always the case. And so just it becomes a logistical challenge, and our pilots do our best to get there, but sometimes they end up having to turn around because of changes in weather. But what that does mean is we have expanded our critical care land assets to be able to help support them. Not only do we have assets in Chatham and Hamilton now from a Southwest perspective, but we actually have one in London as well, so that when the helicopter is not able to fly, we can reassign the crew to the truck to try and be able to support some of those transport movements. Almost lastly, I mean, the other things that impact our ability to do the job that we do is recognizing that we do have a provincial mandate, and sometimes and we have a finite number of assets, and so sometimes we do have to triage to a higher priority call. And while I 100% appreciate that all of these patients need to be moved and they're all high priority, that one of the most challenging jobs as a transport physician is trying to decide who is the most high priority in the region, and how do we best move all of these patients. As with all things, mechanical things break. When they break, they have to be fixed. Fixing helicopters and even ambulances, I have learned, is a challenging thing at times. Similar to other healthcare organizations, staffing sometimes is a challenge, and we have to work within our staffing One of the things that we see is just being able to ensure that we've got all of the appropriate crews all of the time, and being able to respond to some of these patients. Last but not least, and this is my final plug, is landing sites. On-site helipads in Southwest Ontario significantly reduce our transport times. Anytime we are able to land next to your hospital to facilitate a transport, as opposed to at an airport and then have to take local land in and out, we not only are able to do that in a much more efficient and timely fashion. We don't impact local response for 911 calls. Helipads, while not cheap, are not necessarily as expensive as you think. And if you have any influence or want to talk about trying to come up with a way to get a local helipad for your hospital if it doesn't already have one, please reach out to us. We have people that can help provide, while we can't provide all of the information, can certainly help provide some context as to how to get a helipad or a certified helipad. That is the nuanced difference. Helicopter can land anywhere once, I've been told, but a certified helipad at your hospital. And with that, I will stop talking and open it up to questions, because I would think, or I hope there's some, but otherwise we've got about 10 minutes to chat.
Thanks so much, Mike. There is a question in the chat that I want to get to, but before that, I was wondering if you could speak to some of the new stuff that's coming through Ornge, like whole blood, physicians on flights, other things that I probably don't even know about.
Absolutely. So I'm just gonna stop sharing my screen. So yeah, absolutely. So lots of things, new things coming to Ornge for sure. Blood being, for Southwest Ontario, blood being the most recent one. We've been working very hard to bring blood across our entire service. It's about 2 years in Toronto, a year in Thunder Bay, and London just came online about 6 weeks ago now. And so for anybody involved in transfusion services, there's a fair bit of regulation around transporting blood and using blood and storing blood off-site. So we've fortunately been able to work through all of those processes over the last year, and so currently our London asset is transporting 2 units, and any transport has a minimum of 2 units of O negative blood available for it, and we're looking at expanding that across other areas. But then whole blood, yes, we are currently just going through REB and CTO approval for the SWIFT trial, which is a whole blood study in trauma. So we're hoping to have that up and running. It's out of the Toronto base, but as I showed with those overlapping rings, Toronto not infrequently comes down into the Southwest to help support transports in the area. So you may see whole blood. Other things that are coming up, so we are looking at a trial with some physician support, but realistically, this is not something that we'll see very often. Our assets are staffed with critical care paramedics, and those critical care paramedics are the mainstay of our transport. The physicians are really there for support at times. But it's going to be, we continue to be dedicated to the dual critical care paramedic transport system. The one thing that we have been working on is trying to support some of the lower acuity transports and that is going to be done with a dedicated RN. Sorry, not a dedicated, a flight nurse with a PCP paramedic. And sometimes you'll see that with one of the big things that we see is timeliness for our cardiac patients coming from Northern Ontario into Southern Ontario. So London, Kitchener, Hamilton, and the GTA, because they require a level of care, but from a timeliness, they're not acute patients. And so we're building capacity within our system be able to move some of those patients with a RN PCP model on one of our SA carriers.
All right, thank you. I'll get to the ones in the chat. So Lori asked, would the Ornge land ambulance be able to transport patients on high flow? Is that something we as rural hospitals should look at utilizing instead of intubating, etc.?
Yes, so our CCLAs, our Ornge land ambulances, absolutely can transport patients on high flow. So those assets are staffed with critical care paramedics. They have the exact same equipment as our rotor-based assets. So we use the Hamilton T1 as our transport vent, which allows for the transport of high flow, and have larger oxygen cylinders. So it does allow for the transport of high flow even up to 60 liters a minute at an FiO2 of 1. Ideally, we don't want to do that unless it's a very short transport, obviously, because we don't have a lot of flexibility to escalate, and we ideally don't want to intubate in the ambulance in transport if we can avoid it. But absolutely, they can do high flow. We are able to maintain high flow throughout through transport, and I can't give you the exact transport duration right now off the top of my head, but our crews are able to, if you call in and say, I have a patient, they're on an FiO2 of 0.75 and a flow of 50, we are able to do those calculations internally based on the drive time distances to say whether or not we can maintain that high flow for that distance.
Okay, great. Questions keep rolling in, so you got quite a few.
Okay.
Dr. Cameron asked, is the UH helipad salvageable?
That is a complicated question, and as an aviation, as a non-pilot, I can't give you a definitive answer. What I can tell you is it is the challenge is based on its certification and its flight path. Currently, we are not able to fly in and out of it because of changes in the geography around the helipad right now. I know there's been discussions, but I don't know what the outcome of those discussions have been.
Awesome. Tasha Vandervliet asked, what communication takes place when another call comes into the OCC and then downgrades the priority of the patient coming from another sending facility? I think that means like to tell you your patient is taking longer, but Tasha, feel free to jump in.
Okay, so for sure, Tasha, and if I'm not answering your question, just let me know. So from a communication perspective, if a patient is triaged, so let's say you've got patient A who we've told you we are coming to get, and we're en route to get, and then for whatever reason we get another call, and the most appropriate asset for that next call, patient B, takes the asset from patient A. So that from a process perspective is decided by our transport physician. So that decision had to be filtered to our transport physician, who will make a determination as to the priority of those two patients based on not only the clinical condition, the sending facility, time to definitive care, but also what the next available asset is for the original patient that's losing the triage, for lack of a better description. So that goes through our TMP, and that decision is made. From there, either the transport physician, or more commonly, because of timing and efficiency, one of our OCC communications officers will call back to the original sending facility for patient A to say, you know what, unfortunately, there's been a change in the plan at this point because of triage. The asset originally assigned has been redirected. The next available asset will be this, because they will call back and say, you know, I have another asset and it's going to be an extra half hour, or I currently don't have an asset. I anticipate it will be X number of hours before another asset will become available. As I try and tell people, we will never say no. We will never say we will not come. We will eventually come, but we will try and give you information so that you understand when it is likely we will be able to respond next. Does that answer your question? Perfect.
Got a thumbs up. I actually, just because of my experience, can you talk a little bit about how life or limb affects that? Because, you know, it seems like when a life or limb designation's made, it becomes the highest priority, although they might medically not be as sick as some of the other priority ones.
Yeah, so that's a great point, Anton. And I from a life or limb perspective, um, we treat life or limbs within Ornge as a scene call. And what a scene call is an automatic launch for us. So 911, and I'll give a bit of a long answer so that people have a good understanding of it. But essentially, we will launch with limited information, just whatever the 911 call comes in. So life or limbs are done the same. And this comes back to this process of trying to shorten time to definitive care. So if you call in and have a call that's designated life or limb, before we have any information, it comes to our planner. If we have an asset available, they are going to push that information. They will push that to the pilots. The pilots will weather check, and the crew will launch before any of the medical call taking has been completed. But what that also means is that if it's been designated a life or limb and we have an asset on the way to a call, which is an emergent call, but not a life or limb, they will divert that call to the life or limb call. And then from that point, to similar to the last question, we are now in a, we're now moving away from another patient. And so that can be reversed as we get more information and determine that, patient A, though not determined life or limb, is actually more critical than patient B, who has been determined life or limb. But what that means is you've lost a bit of time as that aircraft has turned to go towards the life or limb, because we assume that they are the most critical patient at the moment, and then actually divert them back to the original patient. So that call taking can take anywhere on average of about 15 minutes to get that information and sort it out. So we lose about 15 minutes of time in that diversion.
So I'm just wary of time. We do have 2 more questions, but before people log off, Eric and I just want to make a plug for the future of SWOCCS. So we're going to be taking a summer break here. So enjoy, but we have big plans for the next year and already planning our future lecture series. So keep an eye out for that. We've posted in the chat a new form if everyone can click on that and give us some ideas for next year and what we can do better. We'd really appreciate it. And then all the recordings should be available on the YouTube channel, Critical Care London 7580.
Thanks, Anton. Maybe we'll quickly try and get a couple of these questions done. So question from Kevin Gretzinger. Is Ornge able to collaborate with local ambulances in some way to allow for transport of patients with a large number of drugs on infusion pumps? For example, providing strategies to help mitigate these requests?
Yeah, so we are always happy to help and have discussions with our local land services to talk about how we do it. The challenge that sometimes comes into that is that different land services have different equipment, and different hospitals have different equipment, so it may not always be compatible. And living in London, I can appreciate the UH to Vic corridor challenge. It's much quicker to do it by local land than it is to wait to have Ornge do those. But they have a completely different stretcher system, securing system than we would have at Ornge, but always happy to collaborate with our local services to try and make it more efficient and provide context as to how we do things, and our certifications associated with that. And then the other question about standardization, if my email was up there, it's just mpeddle@Ornge. If you send me an email, I'll happily send you our standardized mixing tables and dosing references. And I'm more than happy to share those to try and help improve standardization.
Okay. Awesome. Any more questions in the last minute we have here?
And if people have questions after the fact, feel free to email me. More than happy to continue the conversation online.
Awesome. Thanks so much, Dr. Peddle. I think this is great. And like we said at the beginning, Ornge is kind of the link between all of our all of our different institutions. So with that, we'll wish everyone a really happy summertime. Enjoy your time and look back for schedule announcements coming in the next couple months about restarting things in September. We really would, one last plug, please fill out the form. Thanks, everyone.
Thanks, everyone.
Everyone, thanks for the invite.